I kind of look at this first talk here as just kind of a setup for what we're going to hear next. We've got some really wonderful speakers coming up talking about all of the important things to consider when we're talking about patients. Just as a bit of an overview, I'm going to go through a couple of things in regards to my risk stratification algorithm, but realistically, just a little bit more to my general thoughts on what the future of all of this really looks like for our patients. I've got, again, the same disclosures that really aren't relevant necessarily to patient risk stratification. So I'll talk a little bit about sort of what patient selection looks like and somewhat what some of the data shows us, and then a little bit on our evolving algorithm. And then to steal from Caitlin's talk earlier, I'll explain why the future is now. So obviously, I like to put in disclaimers because my wife's an attorney and she uses them to keep herself out of trouble. I understand that this may be a bit controversial to some people, but I would argue that in this particular group, many people will probably support where we're gonna end up at the end of my circuitous speaking. So to whomever you attribute this quote, I always find it very useful to remember anytime we talk about data is that most of us tend to use statistics like a drunk uses a lamppost more for support than for illumination. So we'll do our best to illuminate ourselves with some of this data, but keeping in mind, obviously, my biases are that outpatient joints are great and for everybody. And so if I use data to support that, just remember who's talking. Patient selection has a lot of data behind it. There's some great scores developed out there. The Aura score developed by Pete Calcavello and Mike Meneghini out in Indiana is a very good scoring system that people can use. It is a bit, it's quick and easy to use, but some people are a bit intimidated by it because it does have a lot of parts to it. That being said, they've shown a couple of different times, and it's actually been externally validated in a completely separate patient population that is very, very useful at predicting the ability of a patient to be discharged home on the same day of an operation. I think what a lot of us do when we start to think about taking our patients to surgery centers or sending them home on the same day of surgery from the hospital is we start with what shouldn't we do. And I know in a little while, we're going to have some talks about hard stops and who not to schedule. But I think a lot of this revolves around solid organ disease, COPD, CHF, cirrhosis, older patients, chronic smokers, diabetes, steroids. So I think there are some things that we talk about hard stops, and I'm really looking forward to Dr. Kreutzer's talk right after this one on those hard stops. But there's a couple of things I also think that we don't talk enough about, or we're only starting to talk about now. And this is some work we did down with Danielle and Alvin Ong out of the Rothman Institute, where we took a look at some of the social factors associated with patients being able to go home on the same day of surgery. And it turns out that there's some of those things we really need to consider too. So it isn't just the medical side of hard stops. It isn't just the medical things we need to consider. We absolutely need to consider some of the social stuff as well. And when we looked at about 3,000 cases out of our institution, what we found was that, interestingly, it wasn't the medical stuff that stopped our patients from going home. It was somewhat the social stuff. It was actually just their functional status before surgery. And what that reminds us is that there's more to a patient than the ICD-9 and ICD-10 codes for their heart failure and their diabetes. And it's really about understanding what's their home situation like, what's their functional status beforehand. If you couldn't walk down a flight of stairs beforehand, you probably can't go home if you have to walk down a flight of stairs, right? We need to give people some time to train for things they couldn't do before if it wasn't possible. But if you could do it before, you probably can do it right afterwards. And when we look at patient safety, we know that when done correctly, outpatient surgery, same-day discharge surgery is absolutely as safe, if not safer, than inpatient surgery. So it really just comes down to doing it correctly. And I think that's what we're here talking about a lot today. And when we compare hospitals and surgery centers and HOPDs, all of them have similar rates of complications in appropriately selected patients. And the outcomes, again, multi-center studies have shown us many times that the outcomes are the same. So it really leads to the question of what we do for patients when they're actually there in the hospital. And this is really what started to expand my mind on what it means to be an appropriate candidate for an outpatient surgery. Because we spend a lot of time talking about this disease and that disease and this and that. But the real question that patients ask me is like, what do you mean I can go home on the same day of surgery? What about everything I need at the hospital? So it's wonderful that Lenny Buller, one of our old fellows, and Michael Meneghini looked at this and said, well, what do we actually do for patients in the hospital? And when they looked at about 2,000 patients that they kept in the hospital overnight, what it turned out is almost every one of them had absolutely nothing done for them that was of any value. Most common issues that were addressed were oliguria, urinary retention, and hypotension, but 90% of patients had nothing done at all. 9 out of every 10 patients who stays in the hospital has absolutely no reason to be there. And that's what really changed my focus a little bit to make me start thinking that, yeah, we're going to have all these hard stops, and it's important to keep in mind the things we're going to hear over the next 20 to 30 minutes. but the idea of the only young and healthy people being appropriate for same-day discharge is probably inappropriate. This is the HSS inclusion criteria for outpatient surgery from 2021. I was part of making this. This was what we all agreed on as we started to increase our volume, because in about 2018-19, we were doing about 2 or 3% same-day discharge. We now do about 35 to 40% same-day discharge. My own practice is a little more like 70%. But this is what we used. And all I can tell you about this is that it's completely and totally irrelevant. I don't find these very useful at all, because the way I look at it is, realistically, if you're not optimized from a medical perspective or a social perspective to have surgery, then maybe you just shouldn't have surgery. Maybe we can take some time and do work on our patients' medical conditions, on their social conditions, on some of the other determinants that allow them to go home on the same day of surgery, so that if we put a little more resources into these patients up front, they actually have much better outcomes later. And those outcomes can stretch not just to how their hip and knee replacement do, but how is their life doing? How is their general health doing? And when you start to think about global risk taking, when you start to think about looking at it from a more holistic perspective, like we heard some of our partners talk about earlier today, you realize that if we do a little bit more work up front, we get a better result on the back end. So I would argue that realistically, if you can't have an outpatient joint for one of the reasons that for something that can be changed, we should change it first. We shouldn't just do it in the hospital and then let you deal with it later. We should work on those social factors. We should work on those medical factors, and then we could see a better outcome for the patient in the short and long term. And so our job is to use our collective experience to develop strong protocols to evaluate the things that matter: fluid management, prevent oliguria, prevent hypotension, prevent nausea, vomiting, dizziness, urinary retention, medical optimization, and social optimization. And if we do that, every patient is going to be an appropriate patient for outpatients, except for a very small group of people who simply have non-modifiable risk factors. So in conclusion, patient selection is always an evolving conversation. I'm really looking forward to the next half an hour or so of great talks. Risk stratification is important, but realistically, optimization is the key. And we can't say that optimization is just cleared by cardiology and cleared by nephrology, right? Optimization is truly putting them in the best medical, surgical, and social situation for a positive outcome on the other side of the surgery. And all of our programs will be a bit unique in our protocols, but as long as we remember that those protocols need to be evidence-based and patient-centric, we can do this for a lot more patients in the future. Thank you very much.